All right, so we're going to be demonstrating some shock and resuscitation skills. So what we're doing is we're coming into our scene. Our scene is deemed safe. We've listened to dispatch. We know what we're going into. We have a 30-year-old male patient who is responsive but on the ground and is in a supine position when we arrive. We don our BSI. We ensure that the scene is safe. We've checked around to ensure that the scene is safe. We've again listened to what dispatchers had to tell us about the situation. We can see this person is looking at us, so they are visually responsive to us being there as we enter the scene. So we know that they have, that they are at least somewhat alert. We need to assess how alert. If they're responding to me, speaking with them, if they're nodding, if they're responding to my words, they're responsive to the verbal stimulus. So I'm saying, hello, sir, my name is Alex Gato. I'm coming in a place where he can see me. I'm saying, hello, sir, my name is Alex Gato. I'm here with Great Brook Academy, EMS, and we are here to help you. So my partners and I are coming around. We're having a partner potentially hold C-spine in this case if we are in a situation where they have potentially fallen, if they're able to give us that information or not, or if a bystander is able to give us that information. And so we see that this patient has a bleed on their arm. We're doing our assessment. We're looking at our ABCs. So their airway is patent. In this case, they are breathing. Possibly in this case, if they have fallen and they're experiencing some kind of psychogenic shock, they could be very rapidly breathing. If they're looking at their blood and they're getting a little bit panicked and they're acting a little bit anxious, that breathing could kick in. That rapid breathing and shallow breathing, so we might have to monitor that. They do have a pulse. I would check them for a pulse. So taking a pulse, taking the radial pulse, potentially taking a pedal pulse if I had access to their feet as well. And then going from there, we've assessed our ABCs. We're looking for any major injuries now at that point. We're doing a rapid head-to-toe scan. We're feeling as we go down the arm, seeing if there are any other bleeds or any fractures or anything that might be causing potential internal damage that we might not be seeing visibly. And again, we're monitoring them. I'm paying attention to their skin quality, their skin's color quality, and whether or not they might be diaphoretic, potentially sweating quite a bit, or that they are cool. And so the third component being temperature in this case. I want to assess their temperature. I want to assess what their skin color is, if it's pale, if it's pink. If it's pink, it could be more perfused than if it was pale. And this person is pale. We see a little bit of sweat starting to bead on the forehead and the upper lip, which is usually correspondent to potential compensated shock. So again, we are kind of treating this as a compensated shock situation here. So we have our BSI, we have everything set up. We've done our our initial assessment. We have ensured that our patient is in a supine position so that they can be, so that we can provide interventions like CPR if need be, if this patient goes into any form of decompensated shock. But right now, they're in a status of sort of compensated shock. We don't know necessarily. Again, we've just done a rapid head to toe. But again, there might be problems that we don't see necessarily even on our first pass. And I need to assume that there are potential issues that can occur here, and that this might not just be psychogenic shock, but it could be hypovolemic shock. If this bleed that's on the left arm is significant, then there might be an issue where their blood loss, their fluid loss is so significant they could go into hypovolemic shock. And both of those initial shock conditions are the same. So it's very important to look at that skin color, temperature, and quality to ensure that we are saying, okay, this person is in a kind of a state of compensated shock. They could go into decompensated shock, and we got to stop it then so they don't go into irreversible shock where their cells die from inadequate perfusion. We see that their airway is patent. They are breathing, but it's shallow and it's rapid. They do have a pulse. They are responsive to us, at least a little bit, but they might be very anxious. So I want to be speaking to this person as we're going about this, as we're holding C-spine. Again, we're telling them what we're doing. We're making sure that they are okay. And at this point, I would want to, and very early on in this whole situation, I would want to ensure that if I was on scene by myself, I would want a bystander to call 911, request additional support, and potentially, depending on how this patient's status is, potentially ALS support on standby, just in case this patient needs more intense advanced life support care. So we need to ensure that those measures are in place, and we want to be able to begin to get this patient ready for transport, but we need to take care of them while they're here. So what we're going to do is we're going to raise their leg 6 inches off the ground. I have a bucket here that's stable. It's a stable surface. We don't want to put them on anything unstable. We have a bucket that's stable, and I'm going to step off camera to grab this item, but in this case I would have someone or a bystander grab it normally. So what I'm going to grab is a blanket. And the blanket's really important because the blanket allows for the core body temperature of the patient to be maintained, so that when their extremities shunt blood to their core, and eventually that blood gets sent back out to warm the extremities because the body perceives the extremities need to be warmed after a certain period of time, we are ensuring that that vasodilation, that drop in blood pressure, does not result in our patient fainting, losing consciousness. We're monitoring our patient's level of consciousness. Again, we're speaking to them nicely. We're ensuring that they know what's going on. We're here for them, and we are going to help get them through this very difficult situation they're in. They can be very scared, and that's a very important component of psychogenic shock, is that fear effect that you could cause a person to lose consciousness as a result of becoming so anxious that they breathe so shallowly and so rapidly that they pass out. So, covering them with a blanket, keeping their core temperature warm. Blankets on. Great. So, we are reassessing pulse. We're reassessing their vital signs. We are, again, before we cover them, it's also important to say that during that initial and rapid scan and into the primary assessment, we have assessed their injuries. We're not covering them and not having at least checked out the whole portion of their body, because we could be missing a significant injury that we may need some intervention in order to prevent any potential life-threatening effects of that injury from this mechanism of action or nature of their illness. So again, now that they're covered, we have them warm. If they are beginning to show signs of decompensated shock, or if they are if we're unsure of whether they could go into decompensated shock, we want to make sure, if we're assessing a high priority patient, we're doing it every 5 minutes. If this patient was just in a case of psychogenic shock and they begin to come out of that state of anxiety and fear that goes along with that, we can then begin to, using secondary assessment and vital signs, monitor the patient and potentially reassess every 15 minutes if they become a little bit less severe. So that's an important component to this as well, is that reassessment during transport is really important, so that we have a set of vitals to go off of that can give us a baseline for any changes that could occur in our patient, whether they go into decompensated shock from compensated shock, and we need to be able to intervene if that happens so they don't go into irreversible shock, or whether they're in a state where they actually might be coming out of a psychogenic shock and they're okay, and we don't have to reassess them as aggressively every 15 minutes or every 5 minutes, and we can switch to an every 15-minute assessment. So that's what we're going to do. Thank you very much. This is shock and resuscitation.